Good morning, everyone. This is Frank Stichter from Strategic Health Plan Consulting, and we're going to talk today about managing chronic kidney disease and some of the associated costs. Let me give you a little background here first on Strategic Health Plan Consulting. I've been in the business, I'm the president, and I've been in the business for almost 40 years, strictly working in healthcare benefits. Worked for a couple of very large regional agencies. Most of that time I know how brokers and agencies and companies operate. But I kind of got tired of all that and started my own company back in 2015 as an alternative. And at the end of the day, our goal at Strategic Health Plan Consulting is to identify and quantify opportunities that can create compelling savings without changing benefits to employees. And just to kind of give you a little bit of a taste of the problem here, the late Uwe Reinhardt called American employers the sloppiest purchase of healthcare in the world. Back in 2013, Time magazine devoted an entire edition to why medical bills are killing us. First time they've ever devoted the entire edition. And you may have seen in the last couple of years Warren Buffett and his group trying to do what they can to lower costs of health care and health insurance. And this just real quick, this top line here, the top two lines are showing what health insurance premiums have increased over the years. The bottom two have to do with inflation and earnings. As you can see, over time, the gap is getting bigger and bigger and bigger, and it's going to continue. It's out of control. Employees essentially take a pay cut every year because premiums are rising faster than wages. Just a couple other things here. Almost 43 million people, and this is back in 2014, almost 43 million people have unpaid medical debts. It's half of all items on credit reports are medical debts, and it's a big cause of bankruptcies. I think you're understanding where we're going with this. The transactional broker, your traditional broker, and I've been there, done that. We focus on things like stop loss insurance, admin, provider networks, but the big spend is claims. And that's why we're having this webinar today to talk about what we can do to lower those claim costs. So why these webinars? Well, it's aligned with our mission, really, to give you ideas, plans, programs that can create those compelling savings. You can go on YouTube and look up my name and or key in these past seminars on Self-Funding 101, Specialty Drugs and Captives, and watch those videos. We also have some new webinars coming up here on reference-based pricing, oncology management, and third-party administration. I hope you can all take the time to record or to view those videos. But benefits have become increasingly complex and obviously very expensive for a variety of reasons, and every group relies on their broker or consultant to assist them making recommendations and marketing and so forth. But the $64,000 question is really, who on your healthcare team has an incentive for your costs to go down? Well, let's identify the team. Doctors, hospitals, big pharma, your broker, insurance companies, consultants. The reality is that everybody makes more money when your costs go up. And there really is no incentive for anyone to work on your behalf. So you know what you know. You can't research everything and know everything. You just like any other advisor, you trust your broker consultant. But at the end of the day, how do you know you're getting the best information? Because you're only as good as your broker, and you don't know what you don't know. In fact, I wrote a book called You Don't Know What You Don't Know, and it's for employers like yourself that if you'd really like to know more about how brokers and consultants and agencies operate, this is the book for you. So, there's a whole lot more than just shopping around for new insurance companies, for price, for networks, perceived discounts. That's a whole nother story. But the reality is the status quo is unsustainable and unaffordable in its present form. It just you saw the graph where wages aren't keeping up with premiums, and it's unsustainable for employers and unaffordable for employees and employers. So what we're going to talk about today, and I have Ed Gonzalez from Renalogic, is going to talk about management of chronic kidney disease. But Ed and I were talking earlier, and he had said that in 2020, the build, so this is the going build rate, is for dialysis, if we get there, is $1.4 million. Can you imagine that? And really, about 2/3, and Ed can correct me if I'm wrong, but I think about what I've read recently is about 2/3 of all dialysis in this country is handled by 2 publicly traded companies. So when you have kidney disease, can lead to diabetes, to failure, end-stage renal, and ultimately dialysis. So I'm going to turn the ball over to Ed, and he's going to talk about the management of chronic kidney disease so that some of these costs and some of these events don't take place. With that, Ed.
Thank you for the introduction, Frank. My name is Ed Gonzalez. I'm the regional sales director for Renalogic. And today I want to, before we really start talking about our solutions, definitely want to share with you, make sure we have a greater understanding of chronic kidney disease, how it impacts the individuals, the American population, as well as the financial impact it has on employer groups. So we'll talk both about the health impacts and the actual financial impacts to the group.
Did I lose you there?
Yeah, I mean, I see myself speaking, but the slide is gone.
Yep, I'm with you. There we go.
Okay. You can go ahead to the next slide, please. Okay, so first thing is within our group we call chronic kidney disease the silent epidemic. Chronic kidney disease is the 8th leading cause of death in the United States. What's really challenging with chronic kidney disease is that the majority of folks that actually suffer from it are not aware of it. So about 96% of people with mild conditions or mildly reduced kidney function are not aware of it. A big part of that is that our kidney function does diminish as we age. So as we are getting older, most of us will be in, not most of us, but about 40 million Americans, or about 15% of the population is going to be in some state of chronic kidney disease. What's really scary though is going to be the highest risk individuals. So nearly half of people in later stages, and these stages go from stage 1 to 5, 5 being end-stage renal disease, and that's where someone needs dialysis. But 48% of these people that are in that late stage 3 up to almost stage 5 are completely unaware of it. And because of that, most people actually start dialysis in a hospital. So about 80% of all dialysis starts with an emergent start. The financial impact to that to a group would be about 150 to 200,000 for about a 5-day hospital stay, not including the major impact on the psyche of the member and the impact on their families. Consistently, although this is the 8th leading cause of death, it is the 3rd highest catastrophic claim for stop-loss carriers. Unless someone has personally experienced dialysis either through a family member or through a friend, most folks are not really even aware of this disease in a lot of cases. Most commonly in the space for employer groups and for health insurance consultants is going to be they're learning more about chronic kidney disease or dialysis when these claims start coming in and when they start seeing these catastrophic claims impact the health plan. And as I noted, 40 million Americans are currently estimated to have chronic kidney disease. Next slide, please. Okay. So, part of the challenge, and sometimes I have folks ask, is like, well, how in the world can 96% or about half of the people that have late stage not even be aware of this? This is actually an avid talking point. Earlier this year, our clinical team was at the annual conference for the National Kidney Foundation. So this is actually something that challenges the healthcare space overall. Part of that challenge is that Chronic kidney disease is a distinct diagnosis. A lot of practitioners, they're just not comfortable speaking about it just because they're unsure how to address it. Because it is still fairly relatively uncommon compared to things like diabetes, hypertension, and other heart diseases and cancers. A lot of focus tends to be within those existing conditions. So the challenge is, in a lot of cases, people will have hypertension, diabetes, and that's where the practitioner is going to be focused on. And they may even be aware that the member has chronic kidney disease, but they don't want to stress the member by providing them with, oh, by the way, you also have chronic kidney disease. So part of this is kind of reframing that conversation, educating the practitioners on how to speak to it. And a little bit is kind of in the future is what we're really looking at is having that chronic kidney disease in context with cardiovascular risk. So your kidneys clean your blood. And realistically, in a lot of cases, people that have cardiovascular disease or cardiovascular risk are going to be very likely to also have some stage of chronic kidney disease as well. Next slide, please. All right, so this is, I referenced this earlier. These are the 5 stages of chronic kidney disease. I did note that early on, or as we age, we do see some slight dysfunction in our kidneys. Same way we can't run faster. If you run marathons, you can't run as fast. If you lift weights, you can't lift as much as you get older. That's just part of nature. So the same thing happens to our internal organs. But a lot of this is multiplied basically based on lifestyle, right? So if folks are not eating appropriately, if they're not exercising, just like every other disease state, just like diabetes, just like hypertension, other chronic disease states, basically, this is also going to get elevated. So if you don't take care of yourself, if we don't take care of ourselves, we're going to keep progressing through these stages. If we don't improve our diets, folks that do have chronic kidney disease will continue to basically accelerate in their disease state. What's really unique is that to get from, let's say, stage 1 to 3A could take 3 or 4 decades of lifestyle. But then once you get to that later stage, it's kind of a cliff. It becomes harder to manage. Once you've done a significant amount of damage to your kidneys, it's really hard to improve or reverse that damage. So we definitely want to catch those folks early on, although with very strong intervention, lifestyle changes, control of alcohol, tobacco, things of that sort could help reverse a lot of this to at least delay for the folks that are en route to get kidney disease. Part of it is we could help delay that for the most at-risk members to potentially get a transplant so they don't need to go into dialysis. Next slide, please. So this is where the costs come into play. So this also was from that National Kidney Foundation symposium that was earlier this year. So the middle is stage 3. So chronic kidney disease starts impacting the claims cost way before dialysis even becomes an issue. So it's not uncommon for members that are in middle stage chronic kidney disease to cost the plan $2,500 to $3,000 a month in medication, care, things of that sort. So the blue line here represents the prevalence, and that means these are folks that are most likely have chronic kidney disease. The challenge is, in most cases, this goes back to a couple of earlier slides where the practitioner hasn't notified the member or diagnosed the member for chronic kidney disease. And then the red line will represent the members that are diagnosed. It doesn't change the cost, but a lot of this really has to deal with awareness. And quite simply, if a member is not aware, if the plan is not aware, if there's any disease management in place, it's not aware that they have this diagnosis, they're not able to address it and provide the correct recommendations for lifestyle changes to help slow down and improve the health outcomes for those members. If we improve the health outcomes, then we help improve the cost for those members. Next slide, please. So, here's our solution. So there's 2 main things that we do. And one aspect is going to be is managing chronic kidney disease in itself. And the second aspect, as we go further down the arrow, is, for those members that have already reached dialysis, or we really can't prevent them just because they've moved too far ahead, then we want to be able at least to manage the cost for those members. But we also want to make sure that they're getting best outcomes. So, the first aspect is, as I noted earlier, is that, in consideration that so many folks that have chronic kidney disease simply aren't diagnosed, is we have a predictive modeling and artificial intelligence that allows us to review about 43,000 different combinations of claims and identify folks that more than likely have chronic kidney disease or very high risk of advancing into chronic kidney disease, and basically, create an intervention with that member. We have a full clinical team. We have a nephrologist, a chief medical officer who's a nephrologist, who's a kidney doctor. We have registered nurses that reach out to members. This is basically part of it's an intensive clinical strategy where they're going to be reaching out to members to help, number one, educate them about their risk and create a strategy to help those members improve their health outcomes, improve their health. And we do quite a few things, including analyzing medication they're taking, things of that sort. And that's where the kidney dialysis avoidance program comes into play. And very successful. We have situations where members were progressing into dialysis and probably we're 2 months away from dialysis, and we've been able to delay that progression to the point where those members are able to get transplants, or at least delay the onset of dialysis so they're prepared and they're not ending up with a dialysis start in the hospital. Now, there's going to be situations where the member's just going to be too advanced, and we really are not going to be able to help manage that member's chronic kidney disease because they're late stage 4, they're pretty much en route. Sometimes it's genetic, and we have a member advocacy program for that. And this is where we're having same registered nurses that are part of our kidney dialysis avoidance program will do outreach to the member, provide education, explain to them what's happening, and then making sure that they're getting ready for dialysis. So we're going to look at various things. We're going to look at educating them on potential for early transplant, facility navigation, so basically looking at facilities that are going to provide the best outcomes for that member. We're also looking at modality. So one of the ideal things that we would like members to do is to get dialysis at home. And the reason is because when dialysis is done at home, it can be done daily. And this replicates normal kidney function. What this means is members will live longer because the other option is in-center. The challenge with in-center is, number one, it's disruptive. Member has to go into the center for 6 hours a day, 3 times a week. So whether that's in the evening, whether it's during work hours, it's disruptive. They have to travel. If they do it at home, they could do it in their sleep, and they could lead a normal lifestyle in most cases. So we're always going to recommend that to members, and we're going to analyze their situation to make sure that that would be the best modality for them. And then the other factor, basically what we originally were known for is cost containment, is understanding that dialysis just keep getting more expensive year over year. There's 2 major players, that's Fresenius and DaVita, and they own about 75% of the centers in the country, but actually they treat 90% of all dialysis is actually treated by those 2 companies, because a lot of their centers are much larger and they're in more urban areas. A lot of the independent smaller centers are going to be in more rural areas. So they really build their centers where they know they're going to have a high density population. They also build centers that in high risk populations, like by tribal land, by tribal reservations, just because that happens to be one of the populations that are deeply impacted by dialysis. Next slide, please. Okay. So as I noted, our predictive modeling is really designed to help identify that 96% of people that are early stage and just don't know they have it. If you don't manage the people that are early stage, eventually they'll be reaching that stage 3 over time. And those are the members that we showed earlier that are going to cost the plan $2,500 to $3,000 a month. as they get deeper and as they need more medication and more treatment, those members are going to cost $4,000 to $5,000 a month, and that's even before they even need any dialysis. So definitely want to take care of the members that are at risk of progressing, and that's where our predictive analytics come into play. And I already noted 80% of dialysis patients do start in a hospital, so a big part of that is we want to make sure that we're catching people before that happens, and that's where we're analyzing and identifying that 48%, nearly half of the population, that's not even aware. Next slide, please. So this is an example of our predictive analytics and the outcomes. So I do want to point out on the left-hand side, you'll see that these CKD, these chronic kidney disease stages, no claims found. So that means these particular members in this population, and this is a fairly large population. So, normally, this is a pretty large population, more than 10,000 employees within this group. But we'll see is that they have a significant amount of people that have no chronic kidney disease diagnosis, yet they're very high risk. So these, normally this is going to represent someone that's going to be in that mid stage 3, stage 4 level. And we also see that through our predictive analytics that these members have a 72% likelihood or higher of reaching end-stage renal disease within 12 months. I do want to note that in this sample, through our intervention and through our model, that none of these members actually did progress into end-stage renal disease or into dialysis within those 12 months. Next slide, please. So I noted earlier the Kidney Dialysis Avoidance Program. So the values for employers and plans is going to be reduced cost and also avoiding that future high claims cost by basically intervening with those members that are currently lower risk, but we don't want them to continue progressing. So we definitely want to make sure that our nurse coaches are working with those members to help them, change their behavior. Provide best service and education outcomes. Avoid high dollar amount dialysis costs. So we're able to delay the member from progressing or help that member delay long enough so they can get a transplant. Or in some cases, if they're not too deep into dialysis, we can potentially help that member avert dialysis completely as long as they're with our program. For the members themselves, what's really unique about our program is that each member is going to have a dedicated nurse. So when they're working with our group, they're not calling into like a pod. They actually get a direct dial access number to our nurse. They get our nurses. Our nurses work remotely. They work from home. So they actually get the nurse's company issued cell phone. They get a direct email to that nurse. And then we also have a secure text option where the member could download an application. They could text with the nurse as well. So they have direct access to their nurse. Our nurses are scheduling monthly calls with the members. They're reviewing their health outcomes. They're reviewing their progress. They're setting goals. So what they'll do is they'll work with a member. They'll set goals. And as those members progress through those goals, they'll advance those goals. So real quick on that is, we understand that if someone, let's say, drinks 2 big gulps and they smoke 2 packs of cigarette a day, we can't just tell them stop drinking soda and stop smoking. It takes steps. So the first goal potentially would be get down to 1.5 packs or 1 pack, get down to 1 big gulp. And then as we start weaning them off those behaviors, then our nurses will create new goals as they graduate. So, very systematic approach, and definitely have to have a deep understanding that a lot of these members that are in these situations, the reason they're there is because, they've been doing this 30, 40 years. So we want to make sure it does take time to coach these members and to change this behavior. It's not a quick fix. It takes 3 or 6 months. It's not uncommon for us to be working with, several members for 2 or more years. The good thing about that is that by preventing that member from advancing into dialysis, we're preventing the potential for the group from a financial standpoint of seeing a 6 to 7 figure claim year over year should that member get worse. Next slide, please. Okay. So I'm going to focus a little bit more on the cost containment. So we can't save the world. Ideally, we wish we could, but for those members that are going to advance and understand that not everyone that needs our program will opt in. at times, we'll deal with groups, and they may have 60 members that we're managing, and they may have another 40 members that have decided that they're fine, that they'll deal with it. And unfortunately, at times, one or two of those members may continue to progress. This is where our program comes into play, and we want to minimize the impact to the group. The group also still benefits from a nurse. So if we see a member progressing into dialysis, we're going to intervene for the group and make sure that we're coaching that member basically to get best outcomes. As I noted earlier, if at-home dialysis makes sense, we want to make sure they're doing that. We want to make sure that they're getting ready so they don't end up in the hospital. And if there's a potential to help delay any of that, we definitely want to provide that coaching as well to those members. And for the members that do advance into dialysis or in dialysis, we consistently provide up to 91% savings to a group off the build rates. We have a unique pricing model. It's a usual and reasonable methodology. A lot of other cost-containing companies use multiples of Medicare. We've been in business for nearly 20 years, and we've never used that model. The large dialysis organizations have actually created a strategy where they will basically sue a company if they're using a multiple of Medicare. They're considered arbitrary and capricious, and I could definitely answer questions later if there's some more interest in learning more about that. But it's basically become a strategy for the large dialysis organizations to sue groups that are using some form of reference-based pricing that includes a multiple or a Medicare Plus model. And they've done so quite effectively. And there's actually some recent cases that have come up that we'll be reviewing. We actually write quite a bit about this, and we have white papers and things of that sort. So if you're interested in learning more, obviously reach out to Frank, and we'll connect with you folks and through Frank to help answer any of those questions. Next slide, please. Okay, so this kind of touches based on what I just kind of summarized. So the challenges with multiples of Medicare or reference-based pricing is that Medicare uses a very unique pricing methodology. It takes more than 13 separate factors, everything including BMI, age, location, index of what medical staff are paid in the market. So no one really knows what Medicare is going to pay for a specific claim. Only Medicare knows. So the challenge that the dialysis organizations have put forward is that, well, if you don't know exactly what Medicare is paying, how can you state that you're paying us 150, 180% of that? So that's where the legal challenge comes into play. And as I noted, they've done this quite successfully. There are, the other aspect is, PPOs in general, many networks, many TPAs, they're just not able to negotiate incredibly good discounts for employer groups. A lot of networks, their discounts are 10, 20, 30%. There are some exceptions, but in many cases, a lot of the networks cannot simply negotiate with these duopolies. Actually, recently this year, going to 2021, several networks are going to have no contracts with some of these groups. So, we're aware of a couple of TPAs already that have come up that they're not going to be renewing their network agreements with the dialysis organizations because they're not getting good enough discounts. In a lot of cases, those TPAs may be losing business because if you're getting an $800,000 claim discounted, you're not going to be too happy with your network. So that's where we really come into play. And a lot of them are just canceling their agreements and then recommending their clients for us to come in and basically be their cost containment solution. As I noted, our pricing methodology is reaching 20 years. It's non-arbitrary. Basically what we do is we take public and private data. Since these are publicly traded companies, we are able to basically access that public information. The private data, a lot of that is internal because we are repricing thousands of claims month over month. So we're able to basically provide a fair price to the dialysis provider, but that's also not going to, be excessive to the group. As I noted, what that means is at the end of the day is the group is going to save up to 91% on those claims. Next slide, please.
Yeah, if I could interject, Ed, not only if you're talking 10, 20, 30% on a PPO discount off, whatever the charge is, I mean, 91% is extraordinary. But not only will stop-loss carriers offer a discount, because we're talking big bucks here, but you're also talking about lasers for anybody diagnosed, right?
Correct.
So, having this type of program, will either avoid or definitely minimize the amount of that laser.
That's true, and there's so I'm glad you pointed that out, and I hadn't actually touched base on that. So there are quite a few stop-loss groups that if you note to them that you're working with a cost-containment company like Rhenologic, they'll provide they'll remove a laser, some may provide a discount, or they won't necessarily penalize the program. Even if you currently have a member on dialysis, you do get referred sometimes directly by stop losses to their clients and to their consultants. Right. And this is a real world example. So this is a monthly bill for one of our clients. It's been anonymized, but this is this is not even a full month, right? So it's a short month. It's a leap year, but if there was an extra claim in there, there'd probably be this would be closer to 110. But we see this one for February, significant discount here, and then this is what the recommended payment to provider. So this is what the group actually paid to the provider after our repricing. And we see this quite often. Like I said, we process several hundred, if not several thousand of these per month for many clients around the country. And was that the last slide?
Yeah. So really, it's kind of like the program in terms of sequence is similar to like anything else. I mean, early detection, right? Like early detection of cancer or any other condition, but through your data analytics and predictive modeling, that's how you can not only identify members, but also predict how likely they are to even move on the dialysis continuum, right? And then you provide education and self-care to avoid that progression, if possible. And then that one slide where you had those four things, then the advocacy and intervention for those who will get dialysis. And then if it comes to it, we're back to this type of savings.
Right.
Should it go that way? Is that a fair progression there?
That is a fair progression. So we do have quite a few groups that are with our kidney dialysis avoidance program. And the larger the group, the larger the risk is. But I mean, we've had groups with 50 employees, and they'll come to us because they got a member on dialysis. And then so they need our repricing to go into effect, or they have a member that's about to go into dialysis. They're about to reach the renewal period. So we'll go into place to help manage the cost for that group. So, something like this, a smaller group, 50, 150 employees, something like this could take a whole company down. So, but then, as companies grow, as companies are larger, companies with 1,000 or more employees, their risk basically get exemplified. So, understanding that this is not a common disease state, but normally we'll see that probably for every 1,800 employees, and then this is just an average, we'll see at least one member on dialysis for every 1,800 employees. There's going to be specific industries where it is a little bit more common, manufacturing, it's not uncommon for trucking industries, logistic type companies. We will see a higher preponderance of it. A lot of it has to do with lifestyle and just the design of the job. Other aspects are just ethnicity. Tribal groups are highly impacted by diabetes and chronic kidney disease. So a big portion of the population that has, basically we have diabetes and hypertension and cardiovascular disease, you're very likely, if you don't have chronic kidney disease already, you're more likely to advance to it. Just for people that have chronic kidney disease or advanced to dialysis, about half of them have diabetes. So those are all, very comorbid conditions that tend to aggravate the kidneys.
And then, on the claim side, though, I always go back to the numbers, and the prevalence and the expense and whatnot is all very, very good. But if you do end up with like one or two of these, the expense and that even getting 10, 20, 30% on dialysis, I mean, the Bucas of the world, that's the Blue Cross, United, Cigna, Aetna, Humana, they're part of your healthcare team, and there's no incentive for them to have something like this. I mean, at the end of the day, you, the employer, are going to be funding these claims, whether you're partially self-funded or even if you're fully insured, it's all going to end up on your claims experience for your renewal. So having a carve-out program like this can be very, very valuable. So just to kind of segue here, and we'll wrap up and ask if there's any questions out there. But, costs are going to continue to increase. I mean, we all know that. In fact, along those lines, I was having a conversation with an underwriter, several different underwriters at different times. And as we all know, a lot of these hospitals were at one time were thought to be getting flooded by all the COVID cases. So all the non-essential or elective surgeries, testing, all that stuff was put off. And people should have seen their claims costs go down. Certainly mine have. But the expectation of the underwriters, the American Hospital Association expects hospitals by the end of the year to have lost $340 billion. And there's only one way to make that up, and that's to raise prices. And that goes across the board. So the expectation is that, in 2021, costs are going to rise dramatically. So we all know they're going to increase. It's just a matter of how much and when. But you can do the same things you've always done. You can cost shift. That's what employers do a lot. Change insurance companies who say we got bigger discounts. Wellness plans, PBM changes, tools. Or what we're kind of talking about here is what we do at Strategic Health Plan Consulting is we can perform a complimentary financial feasibility study. It's totally confidential, and essentially along the lines of what Ed said in their first step to identify members, we would get those claims, a claims run, and send them to Renologic, and they could do their exercise and with their data analytics and identify members. We can also look at other medical claims, reprice them, pharmacy claims, and actually quantify the financial impact. It is confidential. There's no obligation. There's no cost. And confidential meaning that the only entities that know that this is going on is you, your insurance company, or TPA, and Strategic Health Plan Consulting. This is not changing brokers, consultants. It's confidential, so they won't know. So again, back I said the mission is to identify and quantify opportunities that can create compelling savings without change in benefits. And again, what we do is provide you with a written report of observations, recommendations, and it is quantifiable. Just to give you an idea, this is a publicly traded company that we did. About 2,200 employee lives are in 20 states. Their medical spend was about $32 million. Prescription was a little over 5.5. And we went through all their claims costs, and we were able to save them $10 million, or $4,600 per employee per year. That is considerable. So we have a savings estimator. This is just kind of what it looks like, but our average employer with these programs saves about 28.5%. And depending upon the prevalence of people with chronic kidney disease, that could be significantly higher. But this was a company of about 1,000 employees. Their costs were about $12,000 a year. At the end of the day, we were able to save them $3.4 million, and or new costs of about $8,500 per employee per year. So it is real. It does work. And if you'd like to learn more about that analysis and the claim costs for, sorry about that, for these types of programs, you know, you can reach out to me, and we can get that all started. You see, there is a if I can figure it out here without doing that again. There we go. Well, there was not a question, just a comment by an attendee about their attendance, but I don't see any Q&As out here. Ed, do you have anything you'd like to mention in closing?
Yeah, no, I mean, once again, thank you again, Frank, for the opportunity to speak with folks on this call, on this webinar. And, you know, basically, a lot of this is, you shouldn't wait till you actually have a dialysis claim, because it does take some time to put this in the plan. So if you do see costs, if you've seen costs for members that are $3,000 to $4,000 a month, normally that would fall within our kidney dialysis avoidance program. So we don't just manage chronic kidney disease for those members. We're going to manage all the comorbid related disease states, which are going to include the cardiovascular disease, hypertension, diabetes, lupus. So we're managing multiple disease states that are correlated with chronic kidney disease. So if you're seeing significantly high claims, even if you don't have dialysis, you know, probably we should still connect.
Yeah. All right. Well, and everybody keep an eye out for the upcoming webinars, reference-based pricing, oncology management, and third-party administration. So with that, Ed and I'll say so long and hope to get in touch with some of you soon. Thanks for attending.